I would invite the panelists, Dr. Katyn Kumar, Dr. Rashmi Kapoor, Dr. Anil Sabrey, and Dr. Kanaram Jat to please take your chair. Dr. Katyn Kumar is Assistant Professor, Department of Pediatrics, AIIMS, Bhubaneshwar. Dr. Rashmi Kapoor, she is the Head of Department, Pediatrics, Pulmonology and Critical Care, Regency Hospital, Kanpur. Dr. Anil Kumar Sabrey is the Clinical Lead, Narayana Health. I would like to ask them to please start the session.
Good afternoon, my dear teachers and friends. And a very good afternoon to our lead discussion, Dr. Sushil Kabra sir, and to all my panelists. And basically this is a double-blinded presentation, I can say. Neither you nor my panelists know what cases we are going to discuss. So without wasting much of our time, let us directly go to our first case. So Katyn, this is a 4-year-old child, apparently normally a month back. Cough for about 1 month, breathlessness for about 1 month. There is no fever at all. Weight loss doubtful, 1 kg may be due to machine variations also. Nebulization at times, and the current weight, the 4-year-old child, weight is around 13 kgs and a height of 98 centimeters. So with this scenario, what can be your differential diagnosis, top 2 differential diagnosis from your side?
Sir, before I suggest a differential, one thing that I would want some more clarity on, whether this cough and breathlessness which is there for 1 month, is it there persistently or was there discrete recurrent episodes, and how was the response to nebulization?
It is persistent for the past 1 month. Cough, breathlessness, all persistent for the past 1 month. Nebulization, there is no such response.
Thank you, sir. So in our setting with these symptoms, the first thing that comes to our mind is asthma or reactive airway disease. But since, like you said, there was no satisfactory response to nebulization and the cough was persistent, so that goes out. So now we are probably looking at something like a non-suppurative lung disease which has persisted for at least 1 month. So some subacute onset non-suppurative lung disease. There is not much systemic manifestations, no extrapulmonary manifestations with this history, and there is some weight loss, but there is no fever like you said.
So top 2 differentials.
Yes, sir. So one would be an interstitial lung disease that has started after 2 years of age. So I would think of that, and then a component of that only, some connective tissue disorders with lung involvement.
So very good. So your first diagnosis will be interstitial lung disease that can be due to an surfactant mutation disorders. Another can be a connective tissue disorder, some autoimmune related.
Okay. Could be, sir, definitely.
Yes, sir. Anil, sir.
I mean, with respiratory symptoms of breathlessness, cough, you straight away think of some parenchymal lung disease in these patients, not with much of weight loss. So interstitial lung disease may be acquired in addition to what he said, maybe eosinophilic pneumonias, hypersensitivity pneumonitis, maybe acute, subacute, if it is 1 month. Some infiltrative disorder of recent onset, we don't know. Maybe still late onset immunodeficiencies with some secondary infections which do not cause systemic symptoms, PCPs, CMVs, some infiltrative disorders we don't know, presenting late, like for example Niemann-Pick's storage disorder, because we do not have information about further evaluation. So sarcoidosis, Gaucher's, mucopolysaccharidosis, they can also, in addition, acquired or congenital lung lesions that involve different parts of the lung.
So it can be infective, it can be inflammatory, it can be connective tissue also,
connective
like
tissue,
sarcoidosis.
it could be storage, it could be vascular, lymphatic, lymphangiectasia.
Top 2 from your side, sir, that's all. Top 2
interstitial lung disease, hypersensitivity pneumonitis.
Hypersensitive pneumonitis, yes, sir. So cough is a manifestation of airway, breathlessness is a manifestation whether it produces noisy breathing or not. If it doesn't produce noisy breathing and if it is not associated with fever, we can think in terms of an interstitial lung disease. Yes, sir. So now you are seeing the child, Ram sir, The child's appearance, with this background, the child appearance dull looking, clubbing with respect to grade and 1 and 2, always it will be difficult to say. Respiratory rate for this 4-year-old child at rest is 60 per minute. Intercostal retractions are present, bilateral crepitation, saturation, room air 90% with 2 liter oxygen 96%, rest of the systems are all normal. CVS per abdomen, CNS normal. Ram sir, your diagnosis with respect to this background and history and physical examination?
So in this background, we can think the two things. One is the airway problem, second is the interstitial problem. So because there are no wheezing by the examination also, the history also. So we can say unlikely to the major airways. It may be small airway disease, or in the interstitial problem, it may be still be there. So in interstitials, most likely if the acute onset, there may be the high exposure, there's hypersensitivity pneumonitis may be one of the possibilities. Another possibility, if there is history of this sudden onset, then we can do the foreign body also possibilities. These are two possibilities we can keep.
So again, your top 2 differential with the background of this physical examination.
So in this physical examination, first we will think that this is hypersensitive pneumonitis or other interstitial lung disease, maybe other HP or other interstitial lung disease, ILD.
ILD. So you are more in favor of hypersensitive pneumonitis. Okay, sir. Then let us go to our first level investigation, X-ray. Rashmi madam, comment on this X-ray. A simple comment on this X-ray with this history and physical examination.
So looking at this X-ray, there are multiple diffuse reticular nodular opacities seen in bilateral zones. So looks like a reticular nodular pattern with large nodules here, and it's a diffuse without lung volume loss. It is equally distributed from top to bottom, but more so at the middle and the lower zone, slightly sparing the upper lobes, that as I can see. So that's
okay, as madam said, you have many dots and commas, nothing but reticulonodular pattern involving both middle and lower lobes, sparing some amount of upper lobes. So again, with this X-ray, your top 2 differentials.
So with this X-ray,
Majority of our earlier panelists are more in favor of hypersensitive pneumonitis or an ILD. With this reticulonodular pattern, what might be your differentials?
so the differential, again, it will be any of the ILDs. It could be the granulomatous diseases like LCH, like sarcoidosis. It could be vasculitis syndromes like polyangiitis with granulomatosis. It could be so many differentials. So if it had occupied especially the upper portion, the diagnosis would have been different, but it is, usually a diffuse kind of a thing. So I would say a diffuse disease which is involving all the interstitium.
Your top 2 differentials, that's all.
So top 2 differentials would be, I would say now, granulomatous diseases probably, or a rheumatic cause. It could be
Anil sir,
SLE.
can we vote for TB here?
So
TB in India has to be borne in mind whenever we have a diffuse lung disease. It should not be, because the fever and other things are more nocturnal in our patients when parents do not note. Absence of fever is not really absence of fever.
So can be TB.
It could be TB, but one of the things what madam has said, in addition to that, diffuse alveolar damage, including diffuse alveolar hemorrhage, has to be borne. One other additional possibility to what she has said.
Intrapulmonary bleed. So can also be a possibility.
Yes.
So that with this current scenario, our top differentials are interstitial lung disease, hypersensitive pneumonitis. Many of you have voted for sarcoidosis. Apart from that, pulmonary bleed. Pulmonary bleed. Okay, sir. Okay. Let us see what's happened. So, but none of you have asked for any past history, but there is nothing significant in the past history. Nothing significant in the past history, family history, personal history, nothing significant here. So these are all the possibilities which can come. Is it possible to choose top 1 differentials from each one of you? Top 1 differentials.
Unusual infections.
Unusual infection, name one, sir.
Evolving TCP, evolving CMV.
PCP or CMV, okay. Fungal bar CMV. Madam Rashmi, madam.
So I would think it could be an atypical mycobacteria could cause this, a fungal infection, aspergillosis.
Again, fungal, okay.
Yeah.
Ketan?
So in the absence of fever, I would not consider TB, atypical infections, immunodeficiency upfront. Also, HP would be slightly unlikely if there is no fever and we are sure about that. I would actually like to see further imaging for surfactant-related disorders, especially those which can present slightly late. Except for SFTP-B, the other mutations, those could be considered.
So from your side, absence of constitutional symptoms makes you to rule out infections.
Yeah.
Either it is TB or unusual or immune related.
Yeah,
So
right.
you are in favor of surfactant related.
Yeah,
Done. Ram sir?
So I still keep that because of the short history and the very severe hypoxia, hypersensitive pneumonitis should be the first possibility among these all possibilities.
Okay, then hypersensitive pneumonitis probably acquired from your side. So we have hypersensitive pneumonitis, we have surfactant related, we have sarcoidosis, we have unusual CMV bar fungal. So this is the CT. So, yes sir.
So move fast because it is 14 minutes left.
Then sir. So CT. Ram sir.
So we can see there is a bilateral nodules diffusely randomly distributed and some septal thickening. So we can see definitely look like there are some interstitial lung problems. It may be the both HP or the other interstitial problem like that. Although age is less, but surfactant problem may be also problem. But this is still very short for to have this other surfactant problem related. So still I will keep the possibility of the HP based on this CT.
So there is septal thickening, interstitial thickening, there is ground glass opacity. This is the report given by the specialist radiologist. So we have an acute onset ILD now. Management options and investigation options. Can you choose? Katyn, can you choose? Which one will be your favorite investigation against this background?
So out of these, if I had to pick one investigation, I would go for Lavage cytology.
Lavage cytology. Rashmi ma'am.
Yeah, Lavage cytology would, narrow down a lot of
Yes, sir.
differentials.
We need backup of the primary investigations to give a direction. I mean, obviously the definitive are lavage and cytology.
Lavage, sir, Ram sir. Your one investigations that
So,
can.
Yeah, among this ILD, one of the possibilities are the pulmonary hemorrhage. So first we would like to do the CBC and then second the lavage after the CBC.
Okay.
I mean, even non-invasive investigations now.
So right now the child is worsening. The child is worsening during the admission period. So what management options from your side?
So after sending the investigation for exposure hazards.
So ball cytology, you people
No.
are sending, sir is sending for CBC.
And we are sending bloods for environmental exposure, avian this thing. And obviously, one you can't choose in such diffuse lung disease. You have to have a battery of investigation or algorithm, one followed by
Shall
another.
we go for steroids or not? Or an empirical ATP?
Answer is yes.
Yes.
So I think in the bath cytology, CD4 and CD8 ratio
To look
should
for
be done.
sarcoidosis or hypersensitive pneumonitis.
Yeah, that should
Okay,
be done.
Katyn, choose one drug. Or a combination of in the management options.
Steroids, yeah, they are options, but the more and more I look at the X-ray, it looks like the disease is progressing.
The child is progressing. Disease
The
is
moment,
progressing.
if I was able to do a lavage, I would look at the bowel fluid. If it is milky, like it is described in PAP, I would do a whole lung lavage. And if it is not milky, I would go ahead with steroids.
Okay then, right. So these are all the
Just one
investigations.
comment. If the X-rays are so rapidly worsening, the another possibility may be this poisoning exposure, some inhaled poisons, maybe other possibilities.
The child is worsening over a period of 7 to 10 days. And these are all the investigations that you need. So TB workup in India, negative. Then you are someone, these are all the investigations done outside. IgE turned out to be high. OTPT turned out to be normal. you people were asking about BAL, and you have opted for hemosiderin-laden macrophages, maybe pulmonary bleed turned out to be negative, culture turned out to be negative, BAL cytology neutrophils 80%, but BAL culture turned out to be negative. Again, BAL CB not turned out to be negative. It is neither milky nor blood. So, last but not least, these are all the CBCs, ESRs and CRPs. Look at the ESR, very high. Look at the CRP, very high. And basic simple workup CBC is revealing a total count of 20,000 along with the neutrophils of 84% and lymphocytes of 15%. So, anything further to add in this finally? Or we need to do further test? ACE we have not done. Biopsy we have not done.
I mean, we need further.
There is an inflammatory component. ESR is high, CRP is neutrophil is high.
We need to look for systemic vascular diseases like connective tissue disorder. That should be one of the things that we have not done so far.
So can we go for connective tissue panel, ANCA, ANA, HIV? Sir is opting for HIV.
HIV is something that we need to always rule out in a diffuse lung disease.
Okay, HIV was done. Negative, sir, not mentioned here. Ram sir, you were asking for CBC.
Yes, so here we can say that there will be a component of the inflammation. TLC increase, neutrophils increase, platelets also high 7 lakhs. So this ESR and CRP high. So these are inflammatory conditions. Because fever is not there, likely to infective. So it's more likely inflammatory conditions. For that, I need to run the ANA and ANCA report.
So is it infective or inflammatory? Infective, we need to get some form of growth. So can it be inflammatory or?
So one on the general blood picture would like to know what kind of WBCs, what kind of neutrophils.
Neutrophils are high, that's all, madam.
So they are high, whether they are mature or they are immature. Maybe that would.
We have not done any peripheral smear. Neutrophils are high.
Just high. Because some kind of immune deficiencies could lead to high neutrophil counts and infection like LC.
I'll see some other investigations that were taken at ICH. These are all the investigations taken only at, these are all the only investigations taken at ICH. So, as you said, neutrophils are high, CRP is high, ESR is high, always high. In the past 20 days of admission, total count, CRP, ESR, all are high, despite absence of infection.
I mean, the presence of inflammatory markers may suggest injury. It's not necessary that it's infection. So there may be infection, inflammation, or injury. So systemic vasculitis can cause. Diffuse alveolar hemorrhage still can possible because whenever there
but
is.
But there is not much anemia, sir.
There is anemia. Your hemoglobin is 7.7.
Okay, accepted then. But not to the extent of infiltration. And our BAL turned out to be negative for hemosiderin-laden macrophages.
The BAL has to be just not one. So you have to give BAL, then and repeatedly when you are aspirating, that the returning or third, fourth aspirate may turn out to be dark color or hemorrhagic rather than the first BAL.
So finally, the next slide will be our diagnosis. Finally. So it is an acute onset ILD. Without any other organ involvement, inflammatory markers are very high, neutrophil, ESR, CRP are very, very high, no infections at all, neither TB nor other infections. Because of this increase in neutrophils in the presence of an underlying ILD, we were thinking in terms of something related to, as madam told, something related to neutrophils. And so we did, so this is the background finally, and so we did NBT, nitroblue tetrazolium test, turned out to be in favor of chronic granulomatous disease. So we all know that immunodeficiency will often present with infections, with fever. One manifestation of immunodeficiency is interstitial lung disease. Here, a chronic granulomatous disease, X-linked boy present with an acute onset ILD without any signs of any infection. Unfortunately, we could not do DHR because the boy expired before starting treatment. So finally, what is the worst chronic granulomatous disease presenting as an ILD, neutrophilia, IESR, CRP? Infection we could not document. So the old school thought is, whenever you have neutrophilia, think in terms of infection. But the new school thought is, whenever you have persistent neutrophilia, think in terms of an phagocytic qualitative disorder. Over to Kabra, sir. Your final comments, sir.
Okay, so if a child is presenting previously normal with 4 weeks of cough, but losing weight, think beyond asthma or tuberculosis. Second thing is that if you find on examination some evidence of hypoxia, clubbing, hypoxia, respiratory distress, and X-ray showing diffuse opacities, investigate for appropriate cause. It may turn out to be CGD, but more likely to be other reasons, including environmental exposure.
Okay, sir. Thank you. So the next case, an adolescent...
So try to finish it in 5 minutes.
Okay, sir. An adolescent girl with fever, weight loss and wet cough. So apparently normal till 1 year back. Father died of TB and she is well immunized so far. And the history goes like this: persistent wet cough for about 1 year. Persistent wet cough for about 1 year. Fever 3 months, weight loss 2 kgs in the past 3 months, received multiple courses of antibiotics, started on inhaled corticosteroids elsewhere. Ram sir, your first DD.
So here the obviously the history of the TB in the family, they are the first differential with the tuberculosis. But if there is no tuberculosis, after investigation, then we think the other infections or even the adolescent girls, we can think that this autoimmune disease after ruling the tuberculosis. The first possible tuberculosis, second if the tuberculosis ruled out, then autoimmune disease may be possible.
So in the background of a contact with the TB in a child with the fever and weight cough lasting for more than 2 weeks, invariably we will be thinking in terms of TB, and this is the physical examination. Katyn, the child is undernourished, the child had pan-digital clubbing, bilateral coarse crepitation, left lobe of liver is palpable and spleen is 5 cm below left costal margin. Do you expect this kind of clubbing in tuberculosis? And can we say disseminated TB here?
Sir, hepatosplenomegaly and bilateral coarse crepitations definitely suggest TB, but not clubbing and undernourishment within a period of 1 month. So I would like to consider some underlying immunodeficiencies that can present late, something like CVID.
So immunodeficiency,
yeah.
That's it. Okay. Rashmi madam, ESR is 80, CRP is 100. And albumin is little bit on the lower side, 3 grams, globulin is 4 grams. With this background, so one diagnosis is TB, second diagnosis is immunodeficiency, third diagnosis with this background.
I would consider a rheumatic connective tissue disorder over here. Platelet count is very high, 4 lakh, and ESR is high.
ESR high,
Yeah.
CRP high. Your DD.
So we don't generally see such
Your
high.
DD.
So my DD would be probably connective tissue or vasculitis.
Vasculitis, connective tissue.
Or
And,
a granulomatous disease also.
Okay. Sir,
Yeah, the radiology
with this background X-ray and the CT.
The radiology shows that there is a peribronchial thickening on the right side, the arrow. On the left side, what we see is left lower disease characterized by collapse, consolidation, heterogeneous opacities in the left lower lobe. On the right side, the CT.
Just a simple, sir. There is a bronchiectasis with the left lower lobe destruction. All features of bronchiectasis.
In addition, there is a infiltration on the right side also.
Right upper lobe is also involved. More left lower lobe is involved.
Yeah.
Okay, so there is volume loss, heterogeneous opacity is involved bilaterally, bronchiectasis. Both lobes are involved, but ultrasound abdomen revealed enlarged liver and spleen with internal echoes, multiple enlarged periportal lymph nodes are present. So with this background, so right now we have a child with persistent wet cough, persistent fever and weight loss, along with a background of undernourished child, pan-digital clubbing, coarse crepitations, left lobe of liver is palpable, splenomegaly, hypoalbuminemia and elevated inflammatory markers. So despite all this, our first clear DD was TB, still TB, because the child had lost his father due to TB. But CB naught turned out to be negative. Neither the expectorated sputum nor the lavage. Manto turned out to be normal. So, Ram sir, shall I start ATT? Can I consider this as a clinically diagnosed TB?
No, because such an excessive lung disease there, so we expect the either sputum or this should be positive. So in a very small lesion, we can expect the negative gene expert. But in the extensive lung lesions, we can't expect the negative gene expert.
So that's why despite extensive lung involvement, CB not turned out to be negative. Should I consider any alternative diagnosis?
Wrap up in 1 minute, we should limit to our time assigned.
Other possibilities include fungal infection, non-tubercular mycobacteria, other infiltrative disorder has to be borne if rest of the investigations are negative.
So, any of the differential diagnosis that is mentioned here?
Common variable immunodeficiency with secondary.
So, tuberculosis, negative. Can it be a cystic fibrosis? But sweat test normal, no oily stools, endoscopy, no varices, immunoglobulin profile normal, any malignancy, uric acid, bone marrow normal, connective tissue, we have planned for ANA. So persistent fever, cough, clubbing, bronchiectasis, hepatosplenomegaly. Since all other investigation to support other systems were normal, we wanted to start ATT. We wanted to start ATT. So you all know that before starting ATT, we need to do HIV. Turned out to be positive. So, but unfortunately, after revealing the diagnosis, they absconded. 1 week back, we got the culture report. See, MTB detected, sensitive to R, sensitive to H. So this is a case of disseminated TB along with a background history of HIV. So what is the carry home message in this case? Before proceeding to any primary immunodeficiency, always HIV should be an upfront investigation. And CB naught is not the end one. Before concluding it as a clinically diagnosed TB, send all culture samples for liquid culture, which is gold standard. So, with this spotter, I am stopping, sir.
Stop it. Okay, so what we learned from this discussion is that if there is a multi-system involvement and lungs are part of it, think of infection, immune deficiency, collagen vascular disease. Thank you very much.
Finally, the spotter, sir. Died.
Just one comment. In such
Finally,
case,
spotter, sir.
Yeah. Just one comment with before. Because TB is high possibility, so we can do the BAL also, because culture will take time to coming the report, at least 6 weeks. So culture will give the early report, we are considering the high possibility of TB.
Sir, spotter.
Thank you very much.
Okay, sir. Anyone? So, question to audience.
Thank you.
Yes, sir. So, people usually thought in terms of laryngoshield. So, as sir said, it is internal jugular vein ectasia, which can be identified by means of doing a simple ultrasound. So, thanks for your patient listening.